I want to talk to you today about heroes of PKU A History. First, I have some disclosures. When histories of PKU are written, of course, the three great figures in PKU are always included. Asbjørn Følling, the discoverer of PKU, Horst Bickel, the diet, and Robert Guthrie, newborn screening. This is as it should be. One cannot mention the history of PKU without mentioning these. But the unfortunate part is that often the histories end with these three great figures. And that's not as it should be. And today I want to pay homage to other individuals, great people in the field of biochemical research and in PKU research in particular, who have made PKU, in addition to these great figures, have made PKU what we know today as phenylketonuria. First, Lionel Penrose, the great geneticist in England. Lionel Penrose was the first, really, to appreciate the discovery of PKU by Asbjørn Følling. Now, Asbjørn Følling did not know of Sir Archibald Garrett and his enunciation of inborn errors of metabolism. It was Penrose, just after Fülling's discovery of PKU, who recognized that phenylketonuria represented a classic illustration of the inborn error of metabolism. Archibald Garrett did not think of his inborn errors of metabolism as being particularly important. He called them, in general, metabolic sports. But Lionel Penrose understood that phenylketonuria illustrated that indeed the inborn error of metabolism was not a metabolic sport, and that, as a matter of fact, phenylketonuria represented the importance, the medical importance of the inborn error of metabolism, and we know now today that there's so many other metabolic conditions that illustrate that as well. Lionel Penrose also gave us the term phenylketonuria. Følling had called it oligophrenia phenylpyruvica, or phenylpyruvica oligophrenia, a rather cumbersome term and a pejorative term. Penrose, on the advice, actually, of a pediatrician who worked with him, Dr. Quastel, coined the term phenylketonuria, the term we know today. But even more important, Penrose began to think about a treatment for phenylketonuria. He recognized that there was something in protein that was related to the amount of phenylpyruvic acid in the urine. And at that time, it was felt that phenylpyruvic acid was the toxic element in phenylketonuria. And so he reasoned that if you were to reduce the protein in the diet, one would reduce the phenylpyruvic acid in the urine and would benefit the patient. And so he did that to a patient, a young man with phenylketonuria. He reduced the protein. He found that within the first few days, the phenylpyruvic acid in the urine actually decreased rather remarkably. But because he had to reduce the protein to less than 1/2 of the usual amount of intake of protein, as we would know today, the patient became catabolic within a few more days, and by 8 days of being on this very low protein intake, began to actually increase his phenylpyruvic acid to a greater degree than he had before, and obviously this was unsustainable. So unfortunately, that was not the way that one could reasonably treat phenylketonuria. George Jervis. Dr. George Jervis was a pediatrician as well as a biochemist. He was a refugee from Nazi Germany who came to the eastern part of the United States in the 1930s, knew of phenylketonuria from Germany, and was very interested in investigation into phenylketonuria. And one of the very first things he did in the United States was to canvass institutions for the mentally retarded along the eastern coast. And he was able to identify many individuals on the basis of the urine ferric chloride test in those institutions as having this new disease, really, phenylketonuria. And he began to study these individuals. And he personally saw every one of these people, and he meticulously characterized and reported on the clinical features of these individuals who, of course, had untreated phenylketonuria and were severely mentally retarded, and also many of their biochemical characteristics and their genetic characteristics and their family study. And these 50 cases he reported in 1937 represent today our understanding of the classic severe phenotype of phenylketonuria. We haven't elaborated on that since that time. Dr. Jervis also was very interested in the metabolic abnormality in phenylketonuria. And one of the first things he did at that particular point several years later was to feed phenylalanine to individuals with PKU as well as normal individuals, and to measure the Milan-reacting substances in the urine of these individuals as a measure of tyrosine and tyrosine metabolites that they excreted. And he compared the 10 individuals with PKU with who he gave phenylalanine to normal individuals, and found that normal individuals increased rather remarkably the amount of Milan-reacting tyrosine-type substances in their urine upon being fed phenylalanine, whereas people with PKU did not increase that at all. And so he was able to show in 1947 the in vivo phenylalanine hydroxylation defect in PKU. And then, very, very importantly, a few years later, was able to obtain liver from two individuals with PKU in an institution for the retarded, and compare that to liver specimens that he had from normal individuals. And he was able to show that upon incubating these liver biopsied extracts with phenylalanine, that in normal individuals, tyrosine was made, but in individuals with PKU, there was no synthesis of tyrosine whatsoever. And so in 1953, he reported the first report of a specific investigation and a specific report of the in vitro liver phenylalanine hydroxylation defect in phenylketonuria. Dr. Lewis Wolfe, a biochemist. Dr. Wolfe is now still living in Vancouver, British Columbia, in his 90s, very vigorous 90s, I might add. But earlier, Dr. Wolfe was from England, and he worked at the Great Ormond Street Hospital for Children in London. And he knew of Penrose's interest in the diet for PKU, and he was actually interested in trying to develop some sort of treatment for PKU, and he knew that would be a dietary treatment. He knew of Christensen's work in guinea pigs several years before, which indicated that if you fed, at least in that case, guinea pigs with a large amount of glutamic acid, you could reduce the blood amino acid levels, including phenylalanine. Why? Christensen said because somehow glutamic acid caused the blood amino acids to enter the liver and to sequester within the liver, thereby reducing them in the blood. So Wolfe felt, well, maybe this would work in phenylketonuria. And so he fed for phenylketonurics glutamic acid, but unfortunately that was a failure. But his interest in the treatment of phenylketonuria continued. And this now enters us into the diet discovery. Professor Horst Bickel. At that time, in early 1950s, Bickel was a young pediatrician from Germany who was on his way to the Children's Hospital in Birmingham, England, from having spent a couple of years with Professor Fanconi in Zurich, where he learned about phenylketonuria as well as other inborn errors of metabolism. He was on his way to the Children's Hospital in Birmingham to assume a fellowship position there in pediatrics. On his way, he decided to stop in London and discuss the possibility of treating phenylketonuria with Professor Lewis Wolf. And in that discussion, Lewis Wolf told Bickel about a procedure for removing phenylalanine from a casein hydrolysate using a charcoal resin column. The casein hydrolysate put down the column, and the eluate that came out of the bottom of the column did not have phenylalanine in it. It did not have some of the other aromatic amino acids. And he said, well, maybe this could be used as a diet for PKU. Bickel then went on to Birmingham, and within a very, very few months, diagnosed PKU in a young girl, 3 or 4-year-old girl, who had been sent to the hospital from Ireland for investigation of mental retardation. This girl, as perhaps many of you in the audience know, is named Sheila. She's a very famous name within the annals of the diet for PKU. And when he diagnosed PKU, he recognized that this was an opportunity to try a diet out. So he went back to London, he spoke with Dr. Wolf, and Dr. Wolf then explained to him how this diet could be prepared with this charcoal resin column. He then took that information back to Birmingham. The charcoal resin column was set up in the biochemical laboratory of Evelyn Hickman's, and they prepared, of course, the famous diet, which was low in phenylalanine for PKU, fed it to this little girl, Sheila, and showed very distinctly the benefit of phenylalanine restriction in the diet in phenylketonuria. And as a matter of fact, very soon thereafter, Wolf was very interested in really examining this diet a little bit more carefully because Bickel, of course, did not have the opportunity to actually measure the IQ in Sheila. He saw the benefit neurologically, and that is very well illustrated in a film, which, by the way, if anyone is interested in it, can get in our website for the New England Consortium. It is the original film that Professor Bickel made of this girl, and it's a very telling and a very dramatic illustration of the benefit of the diet in someone who is already damaged from PKU but can be improved neurologically. But Wolf was interested in following the IQ of these individuals, and he said in his paper in which he measured IQ of individuals who were late treated with PKU who had been treated on diet, he says, it is known that protein hydrolysates can be freed from phenylalanine as well as freed from tyrosine and tryptophan by passing through a column of charcoal. And this was a report that he was aware of that had occurred about 10 or so years before from Germany. And this was suggested by one of us, meaning Lewis Wolf, to Dr. Bickel, and then he mentioned that no psychometric measurements were made. And as a matter of fact, Bickel himself recognized the contribution of Dr. Wolf to his discovery. He said Dr. Wolf first drew our attention to the technique of removing phenylalanine from casein hydrolysate. So without Lewis Wolf, there would have been no diet that was developed by Dr. Bickel, and I think he and Wolf and others fully appreciated that. Wolf did one other thing, which is not understood and not known. Wolf was behind the cloning of the gene for phenylalanine hydroxylase. And this occurred in the following way. When Savio Wu, who did eventually clone the gene for phenylalanine hydroxylase, was a young investigator from Hong Kong, he went to the laboratory of Dr. Wolf, who by this time had moved from London to British Columbia, to Vancouver, to the University of British Columbia, where he headed the biochemistry laboratory for the neurology and psychiatric department. And Savio Wu wanted to work with Dr. Wolf. And so when he came to Dr. Wolf's laboratory, he was given a project. And the project was to isolate and determine the properties of human phenylalanine hydroxylase. That had not been done. Savio Wu was a very brilliant laboratory investigator, He was able to do this, and he was able to prove and report the very first report of the isolation properties of phenyl hydroxylase in liver. But what is more important is that he used this technique to isolate the phenyl hydroxylase from rat liver. And he used the rat liver isolated phenylalanine hydroxylase to prepare a rabbit antibody which he was able to use to capture the RNA in the rat eventually, and was able to therefore clone the gene through reverse transcription, and therefore clone rat cDNA, and from that was able to clone human cDNA, or the human phenyl hydroxylase gene. So Wolf was indirectly, but very importantly, responsible for the cloning of the gene by Savio Wu. Seymour Kaufman, the great biochemist at the National Institutes of Health in America. Everything we know today about the basis of all that we know today in terms of the function of phenylalanine hydroxylase comes from the work of Seymour Kaufman. It is hard to overestimate his importance in our understanding of the basic mechanism behind the biochemical abnormality in PKU. When Seymour Kaufman first began work at the National Institute of Health back in the early 50s, this was the pathway for phenylalanine hydroxylation and the defect in PKU. It was a simple pathway, people said. It just amounted to an enzyme, phenylalanine hydroxylase, which was defective in PKU, and therefore you got an elevation of phenylalanine and a lowering of tyrosine and the phenylalanine metabolites that accrued as a result of the elevation of phenylalanine. But Seymour Kaufman recognized very quickly that it wasn't such a simple pathway. When he isolated phenylalanine hydroxylase and looked at it as a hydroxylating enzyme, he was not able to get the conversion of phenylalanine to tyrosine when he purified the enzyme. When he used a non-purified enzyme, he found that the conversion in the normal liver actually occurred. Normal animal liver actually occurred. And so he reasoned that there was something that was mixed up in this isolation of phenylalanine hydroxylase that was necessary for the hydroxylation process itself. And of course, we know today, he eventually characterized that something as being a reduced pterin, which we know today as tetrahydrobiopterin. As a matter of fact, as he later identified specifically as tetrahydrobiopterin. In 1958, he reported this as a new cofactor required for the enzymatic conversion of phenylalanine to tyrosine. He went further than that. Seymour Kaufman then began to think about this, and he said, you know, maybe not all elevated phenylalanine is what we call PKU. Not all elevated phenylalanine is due to a defect in the enzyme, because you've got a cofactor which is necessary for the function of the enzyme. Suppose that there were an individual who lacked the cofactor, and he or she would also have an elevation of phenylalanine. And so therefore, there might be something else about that we are calling, quote, PKU, that's not truly PKU. And he went on to say that, as a matter of fact, this factor could be dihydropteridine reductase, which he knew to be a recycling enzyme for tetrahydrobiopterin at that time. He says that maybe a lack of dihydropteridine reductase is a possible variant. Presumably, the consequences of lacking this enzyme might be the same as the lack of the cofactor itself. And sure enough, within a few years, there came a report from London, Isabel Smith and the group at Great Ormond Street, who reported a new variant of phenylketonuria with progressive neurological illness unresponsive to phenylalanine restriction. What they reported were 3 individuals, 2 in one family, children who were identified as having, quote, PKU because they had an elevation of phenylalanine in newborn screening were put on treatment, a low phenylalanine diet. But unlike all the other individuals with phenylketonuria that they were treating at that time, these 3 individuals developed severe neurologic disease despite early treatment and good metabolic control, and very, very severe cognitive defects, and they had seizures and dystonia and things of that nature. And so it was very evident to them that there was something different about these 3 children than the usual child with phenylketonuria. And they reasoned that perhaps it was something relating to maybe the cofactor for phenylalanine hydroxylase. And at about the same time, Seymour Kaufman became aware of a patient at Johns Hopkins Hospital who had the same phenotype, having been identified as having PKU from newborn screening and yet becoming severely neurologically impaired despite early dietary optimal treatment. And he was able to get a liver from that patient, and he examined that liver. And what he found in the liver was that the biopterin in the liver was markedly reduced. He also found that the phenylalanine hydroxylase activity in the liver was reduced. But when he added tetrahydrobiopterin to the mixture that he was examining, the liver mixture, he was able to restore phenylalanine hydroxylase activity. And he therefore knew at that point that it was a tetrahydrobiopterin deficiency situation. And he then knew of dihydropteridine reductase, measured that enzyme, and found that indeed it was reduced. And so he reported the first report of BH4 deficiency as a cause of, quote, phenylketonuria, but in this case due to a lack of the recycling enzyme dihydropteridine reductase that we know so well and that Nenad Blau has told us so much about in the years since then, and who has expanded our knowledge tremendously in this particular area. But it all stems from the original work of Dr. Seymour Kaufman. And then a few years later, he was able to get liver material from another patient with the same phenotype, and he was able to examine that and found out that that patient did not have dihydropteridine reductase deficiency, did have a cofactor deficiency, however, and that it was not due to a recycling enzyme defect, it was due to a synthetic defect, a defect in the synthesis of tetrahydrobiopterin, and of course we know that is due to any one of a number of different defects that, again, Professor Blau has told us so much about. So it was really back then that Dr. Kaufman told us just about everything we knew about the cofactor deficiencies as mimicking phenylketonuria, but being very importantly different from phenylketonuria, and of course needing a very, very different form of treatment in order to prevent the problems that they would otherwise have. And then Dr. Kaufman began to think about tetrahydrobiopterin, and he began to think, well, you know, maybe you could stimulate phenylalanine hydroxylase even in the normal state with increased amounts of reduced pterin. And so he examined rat liver, and he found that indeed, even in the normal rat liver, if he added large amounts of reduced pterin to the mixture, he was able to actually enhance the phenylalanine hydroxylase activity. He began to think about this and said, well, maybe this finding opens up the possibility of treating phenylketonurics who still possess some residual phenylalanine hydroxylase activity with a tetrahydropterin. And of course, we know today that that's absolutely true, and that it is a form of PKU which we now call BH4 responsive phenylketonuria. but Dr. Kaufman was prescient in this way back in 1975. And it was quite a number of years later when Kure in Japan showed that indeed what Dr. Kaufman predicted is absolutely true, and that, as a matter of fact, in some individuals with phenylketonuria, if you give pharmacologic amounts of BH4, as we know so well, you can reduce the blood phenylalanine level. He showed this in 4 out of 5 patients in 1999, and that launched the BH4 responsive form of phenylketonuria, which we talk about today, and the new ancillary treatment for phenylketonuria using BH4 that is effective in quite a number of patients. Now, many of you in the audience, and certainly this is true for students that I tell the story to, believe that when Guthrie developed the newborn screening for phenylketonuria with the idea of preventing mental retardation from this disease, that it would be accepted by everybody. And everybody would say, oh, obviously this is something we should do on every single newborn. Well, very much differently. That was not true, certainly not in the United States when he developed this in 1963. As a matter of fact, there was a great deal of opposition to applying a routine test for phenylketonuria to populations of newborns. As a matter of fact, Guthrie developed this in New York. He tried to get the Public Health Department in New York to institute this as a routine procedure in newborns born in New York, and they refused absolutely. They said that it is ridiculous to examine all newborns in our state for a disease like phenylketonuria, which has such a low frequency. It was a waste of time. But in Massachusetts, Dr. Robert McCready, who is on the left-hand side here of the slide, was director of the diagnostic laboratories in the Department of Public Health. And he was interested in the prevention of mental retardation, as was Dr. Guthrie. And he knew of Dr. Guthrie's test. He had met Dr. Guthrie at a meeting, and Dr. Guthrie had told him about this new test he had. And Dr. McCready said, you know, I can do this in Massachusetts. So he brought Dr. Guthrie's test down to the Public Health Laboratory in Massachusetts, was able to get all the hospitals in Massachusetts to send a filter paper blood specimen from the babies who were born in those hospitals. And miraculously enough, within the first 53,000 specimens that he tested, 9 cases of phenylketonuria were identified, an amazingly high frequency. He reported this as a letter to the editor in the New England Journal of Medicine, and also in Lancet, and also in Journal of Pediatrics, and immediately that interested many, many people within the United States in the routine newborn screening for phenylketonuria. And they recognized, therefore, the importance of this. And as a matter of fact, Robert Guthrie recognized how important what Dr. McCready did was to the introduction and to the acceptance of newborn screening for PKU in his article, in Dr. Guthrie's article about the origin of newborn screening. He says that the first 53,009 cases were identified. He says he published these results, which he did in letters to the editor. He said this was a major factor in the adoption of PKU screening by other states. As a matter of fact, I have a personal interest in Dr. McCready. I went over to the public. I was interested in newborn screening early in my metabolic career. I went over to the Public Health Laboratories in Massachusetts, where there was already a very active newborn screening program going not only for PKU, but for galactosemia and maple syrup urine disease and homocystinuria, all of which interested me a great deal. And of course, I met through that interest Dr. McCready, and he took me under his wing, and I'm forever grateful for that. And as a matter of fact, one of the things that he told me early on is about this thing called maternal PKU, which I had never heard of. And he said, you know, this is a very important part of phenylketonuria, and it causes very severe mental retardation, brain damage, and neurologic deficits and congenital heart disease in the offspring, not because the offspring have PKU, because the mother has PKU, and it can be treated and this can be prevented. And as a matter of fact, we should educate obstetricians about this because they're the ones who see these mothers. And so out of that came this article by us in the American Journal of Obstetrics and Gynecology. It was my introduction to maternal PKU, which has been a lifelong interest of mine. And again, I'm forever grateful to Dr. McCready for that. David MacDonald. Now, where would we be in PKU research today without the PKU mouse? Well, we would not be very far, I can tell you, and we certainly wouldn't be where we are today. Dr. MacDonald was working, a young researcher working in Wisconsin with the group, and he, along with that group, were able to develop a natural animal model for PKU. The way they did this was to identify mice who were carriers of PKU, just as we would people for that matter. They inbred those mice, and so eventually they produced a mouse with PKU. A natural model, not an artificial model, not a homologous recombined model, but a natural model for PKU. It is probably the best model we have for almost any genetic disease today. Again, it's instrumental in the research that we're doing today in PKU. And finally, Charles Scriver. Dr. Scriver was the second recipient of the Asbjørn Følling Award. He is a giant in the field of metabolic disease, and particularly in PKU. It is hard to talk about any history of PKU without including Charles Scriver. Early on, Scriver recognized how important phenylketonuria was to understanding all of the metabolic disorders. And he published this two-part series in the New England Journal of Medicine in 1980 called Phenylketonuria, Epitome of Human Biochemical Genetics. And what Dr. Scriver said was that whatever we know about phenylketonuria can be directly applied to all the other inborn errors of metabolism, all of the other biochemical genetic defects. And so if we learn about PKU, we can then take that information, put it into another biochemical defect, and we will then understand that other inborn error of metabolism. It was a brilliant, brilliant concept. It is very true. It was true then. It is even more true today. So he recognized the importance of understanding phenylketonuria, not only because of phenylketonuria itself, but because what it told us about the entire field of biochemical genetics. He and his group also developed the in vivo phenylalanine hydroxylase assay, which has been used over and over and over again in research in phenylketonuria. And Ania Muntau used it so beautifully in her original study of the BH4 responsive, in vivo BH4 responsiveness in phenylketonuria that she published in the New England Journal of Medicine a number of years before. An in vivo assay in which stable isotope phenylalanine is given, and the breath test. Stable isotope carbon dioxide is measured as a measure of the oxidation of phenylalanine, an invaluable test. And more recently, phenylalanine ammonia lyase is a direct result of the experiments and the input that Dr. Scriver and his group have had. Phenylalanine ammonia lyase was known for many, many years as a method of reducing the phenylalanine in phenylketonuria. It was used in London in 3 patients, and it was used before that in upstate New York, in Buffalo, New York, to reduce. But the problem was that one had to extract from yeast the phenylalanine ammonia lyase. And so therefore you could not get nearly enough phenylalanine ammonia lyase to make it an effective treatment for PKU. what Dr. Scriven's group did was clone the gene. And so today, the clone gene is used as PAL, PEG-PAL now, for experiments in terms of developing this as a new therapeutic treatment for phenylketonuria. Again, a result of the great input that Dr. Scriver has had in the field of PKU. So I will leave you with this thought. None of us is an island unto himself. We are all on the shoulders of those who've come before us. It's never more true than it is with PKU. This is a photo of my wife's father and his friends who are illustrating that point as well as anything that I can think of. So again, I thank you for your attention. I thank Serono for sponsoring the award, and I thank members of the committee for having chosen me for this year's Asbjørn Følling Award. Thank you very much. Thank you.